Are you an evidence-based chiropractor? Seems like a rhetorical question. Of course you are, or some pseudonym versions such as evidence-informed, evidence-directed, evidence-guided, etc. Yet there are those in our profession who misunderstand the concept as meaning everything we do must have literature evidence to allow us to perform our exam and treatment. And so they strongly disagree that they are or want to be evidence-based. But we also have the opposite problem of those who accept and embrace the idea of being evidence-based without understanding or pursuing the available literature evidence as part of the composite of being truly evidence-based. An interesting phenomenon has occurred over the last 25 years or so. We in chiropractic have gone from having almost no literature evidence to a significant amount of research publication. The pendulum has swung. This was an intentional evolution catalyzed by a consortium of a few researchers with an agenda to educate more and more researchers to fill the existing void and to find sources of funding. This has largely occurred and continues to grow. Also, chiropractic colleges have made attempts through national grants such as R25s and curricular redesign to prepare students for accessing and interpreting the literature, sowing the seed for future evidence-based practitioners. Many have accepted and embraced the principles of EB practice because there is a belief that accepting and adopting this position of being evidence-based facilitates endorsement for what we do, and the hope that this increased validation engenders a sense of trust by patients and other healthcare providers. But are we dealing with a phenomenon related to buzzword recognition and the co-opting of that as a strategy for specific purposes? As an example, let's look at how the term organic has morphed from its original connotation. Broadly interpreted, it simply means living versus not, so most foods already had met that qualification. But of course, that wasn't the intention. The intention was to differentiate food that was grown or raised without artificial fertilizers, GMOs, pesticides, growth regulators, or food additives, and that animals were raised humanely. Most also assumed that these were small, local farms. Quite a number of criteria to fulfill. Industry recognized the value of co-opting the term and felt justified that as long as some of these criteria were met, it was acceptable and profitable to use the term organic. So, has the same thing happened with evidence-based? Here are the three components. Two, in essence, already existed for most practitioners: expert opinion and patient preference. So requiring only these two does not differentiate one practitioner from another. In essence, if you practice, you are evidence-based if these two qualifications are all that are necessary. In fact, these two components, expert opinion and patient preference, are primarily passive events. You already learned what to do in practice in order to qualify to practice, so although practice may be work, observation of patient results is largely passive. This forms your expert opinion. Patient preference is also largely passive, assuming you inform the patient of options and your plan and then ask. But the third component, integration of the best available research, requires training and application. Although the basics can be learned in a few hours, most avoid the statistical jargon and rely on their experience or simplified summaries or op-eds, especially if they agree with the individual's opinion. This minimalist approach may allow them to form an opinion, but not one that is truly literature-informed. So, if not fluent in the process and language of statistics, what price is paid? Well, let's look at how research can impact our perceptions and also how it's been used, abused, and in some cases, the excuses for not using it. So there is little doubt as to what the term evidence-based is intended to convey as illustrated by the ACA interpretation, and certainly all EB groups involved in this movement would agree. The practice of evidence-based medicine means integrating individual clinical experience with the best available external clinical evidence from systematic research. Yet again, individuals and groups with an agenda or special interests have co-opted the term for their purposes, not bad in and of itself, but buyer beware. For example, evidence-based has been used to further professional distinction, practice management, patient recruitment, and student recruitment. So, as a potential chiropractic student, if trying to distinguish which colleges are more evidence-based, this Google search illustrates there's no distinction. All are on board, at least as it relates to student recruitment. Do you believe, though, that the Southern California University of Health Sciences, Life University, and Northwestern University of Health Sciences are similar in their approach to the presentation of and integration of literature evidence? Well, how about practice management and patient recruitment? There are a few sites that utilize the term evidence-based as a marketing approach and patient management approach. The first is the Institute for Evidence-Based Chiropractic, created and operated by a researcher. The second, the Evidence-Based Chiropractor, again attempts to inform practitioners of the most recent evidence and integration into practice. The approach is to market the idea that being evidence-based will increase your success with management, recruitment of patients, and referral from other healthcare professionals. And we would hope this to be true. And the third, ChiroUp, offers a fully integrated model of incorporating the most recent evidence into patient management approaches. Notice they focus on another commonly utilized term, best practices. Most assume this is the same as evidence-based, and in part, this is correct if the best available literature is incorporated into practice. But to be clear, best practices goes beyond that. To be specific, best practices requires that practitioners are capturing data in their own practices, and that this is pooled and shared to determine which approaches work best for which conditions. This is not a reality yet for our profession, although the seeds are being sown in comparative effectiveness research. And note, I said data, not opinion or generalized observation. In other words, it isn't what you post on a social media site, but actually a systematic sharing of actual data from your practice. Capturing the practitioner interested in evidence-based practice and best practices can potentially be a great way to distinguish those who choose to ignore the literature, as long as these sites themselves focus on the integration of scientific evidence into their management and recruitment approaches. Yet there is still an element of trust by the user that what is being reported is the whole truth and nothing but the truth. It's clear that these sites are ethical and well-intentioned. However, which evidence is reported, how it's reported, may be flawed, and these flaws may be missed by those who don't seek the specifics but accept the quick summaries or headlines. They don't have the skills or perhaps the energy to do so. That can be remedied, as we will see. So what am I getting at here? With the encouraging expansion of the principles of evidence-based and the hope of capturing a large cohort of like-minded individuals, we may have inadvertently diminished the role of actually individually accessing and interpreting the literature. Without it, one might better regard themselves as an enthusiast or admirer of evidence-based practice, but not actually a fully integrated evidence-based practitioner. So how would you know if you're actually evidence-based? We'll take the following quiz regarding research. Do you understand the basics of research, including the difference between interventional versus observational studies, the hierarchy of study design, including systematic reviews, meta-analysis, randomized controlled trials, cohort prospective studies, case control retrospective studies, and case series and case reports? Do you understand the difference between descriptive versus inferential statistics, the difference between statistical versus clinical significance, and descriptive statistics such as risk ratios, odds ratios, mean differences, effect sizes, minimal clinically important differences, numbers needed to treat, and the purpose of correlation and regression analysis? And finally, for diagnostic studies, the difference between sensitivity versus specificity, positive and negative predictive values, likelihood ratios, kappa coefficients, and intra-class coefficients. So why is this so important? Some would argue this is the language and expertise of researchers and statisticians, and that is correct. However, how can you interpret the results of a study if you don't know how studies are performed, measured, and judged, and the terminology associated with that? You have the obligation of a user. You're likely not a computer engineer, but you must know enough to use one. Individuals make the mistake that because they can read the abstract of an article or a headline about an article, they understand literature evidence, what its purpose is, and how to judge quality. That skill set, though, is rarely present for one simple reason. It was never learned, or it's been forgotten. So what is the skill? It's numeracy. You are literate, but can you translate the results of a study expressed as numbers and statistical terms into meaningful explanations? This is numeracy. So why does any of this matter? Let's look at some examples of how evidence is reported in social media and how, without appropriate knowledge of the purpose, design, and reporting of results, you're manipulated into believing what the poster or blogger wants you to believe. So let's look first for headline, eye-catching phrases or stats. Here's a LinkedIn post asking if your child suffers from ear infections, and then posting what looks like significant results, 75% improved within 10 days or less. But let's look closer. Here's the study entitled Ear Infection, a retrospective study examining improvement from chiropractic care and analyzing for influencing factors. So we know several things. It was published in the Journal of Manipulative and Physiological Therapeutics in 1996. This is one study in a private practitioner's office. It's retrospective, but it's a case series and dependent on the reporting of symptoms by parents. There were 46 children, ages 5 years and younger. Results? 93% of all episodes improved, 75% in 10 days or fewer, and 43% with only 1 or 2 treatments. The researchers claim that there was, quote, very little data found regarding the natural course of ear infections, unquote. So, how can this be rephrased to represent more an evidence-based statement? This is a single retrospective case series study of children with symptoms of ear infection published in JMPT in the late 1990s, demonstrating improvement in 75% of children within 10 days when treated chiropractically. A reminder that retrospective studies by design cannot be used to demonstrate cause and effect, and certainly not a case series. The approach was proprietary, meaning it was specifically developed by the single practitioner in the study. Although the authors claim there was little evidence on the natural history of ear infection, a quick PubMed search revealed we actually do have the evidence about the usual limit of symptoms for children with ear infections. 61% of children with acute otitis media symptoms improved within 24 hours and 80% within 2 to 3 days, and so it doesn't appear that those that improved in the study beat that natural history. We don't even know if they had an ear infection, just the signs of ear infection. We do know that allergies, viral infections, and smoke can also cause similar symptoms. So what did you need to know? That case series are at the bottom of the evidence pile due to their lack of statistical requirements and high bias. What did we learn? Well, case series and case reports are simply observational without a comparison group. Without comparison to a group without chiropractic care or placebo or sham, it's not possible to determine a true difference, a statistical difference between those treated chiropractically and not. You can't use statistics due to lack of a comparison group. They're at the bottom of the hierarchy period, so you are obliged to find higher level evidence when possible, and certainly systematic review if possible. And regarding a systematic review, there are several. The one below is consistent with all others, saying the evidence is inconclusive. And here's an intriguing headline from apparently Reuters. New study from the Chiropractic Doctors Association of Hong Kong finds chiropractic care reliefs tension, headache, and long-term depression. Yes, it says reliefs, your first clue. Further, quote, a new study by investigators in psychiatry and chiropractic at the New York Medical Group found that patient, yes, I said patient, suffering from tension headache and major depression has the long-term relief after chiropractic adjustment, unquote. Do you believe this is actually posted by Reuters Health? I guess they need a new copy editor. Well, first of all, we see this as a case report, meaning only one patient. Secondly, we learn nothing new in the abstract. Instead, some tangential, hypothetical rambling about why she might have improved. Again, not clear why a team of psychiatrists and chiropractors was needed for this one case. This is more than disappointing, and nothing like the implications from the post. Here's another from the same, quote, researcher, unquote. Bridging the gap between observation-embraced treatment for adolescent idiopathic scoliosis. Again, a single case. The curves were 26 degrees in the thoracic and 23 degrees in the lumbar region. After 6 months, they noted an improvement of 6 degrees in the thoracic and 7 degrees in the lumbar region. But of course, they reported as a percentage of improvement. So this then augments the perceived degree of benefit to 23% and 30% improvement respectively. Problems? Well, number one, curves in this range sometimes spontaneously improve or don't progress. Also, the Cobb angle measurement has an error range of about 3 to 5 degrees, which would potentially contribute to the observed benefit. So although a potential good start to a larger study, this single case, with the potential contribution of some error in marking and interpretation, in no way proves or even substantially suggests that chiropractic is yet an option. Perhaps it could be called emerging evidence at best. So what did you need to know? Well, again, case reports are at the bottom of the hierarchy of evidence. What did we learn? Case reports are simply observational without a comparison. They can't use statistics due to lack of a comparison group. And from the scoliosis case report, compare outcome measures to determine the margin of error in measurement. And for adolescent idiopathic scoliosis, compare to natural history. And of course, search for higher levels of evidence, including systematic reviews. In fact, a recent systematic review of AIS failed to find any studies that currently demonstrate significant effects beyond natural history, as much as we would like to believe that manipulation is of benefit. Another post on LinkedIn suggesting that, quote, a chiropractic adjustment can give your system the opportunity to fight disease better. Did you know spinal adjustive care increases immunity and decreases risk for infections? Go to the chiropractor, unquote. Except this was published in the Journal of the Osteopathic Association, and it was not only not chiropractic, but also not an adjustment. It was, in fact, a lymphatic drainage approach. The small increases in certain plasma cytokines were measured immediately after with no long-term follow-up to determine the duration of effect. So, therefore, we have no idea of the significance or lack thereof of this single marker that is indirectly involved in immune reactions. What did we learn? Check your references. Let's move to actual studies. Here's a recent controversial study. The researchers hypothesized that a hypolordotic cervical curve may have an effect on vascular supply to the brain. So they used magnetic resonance angiography to measure blood flow to the brain in supine patients. Then they used a correction device to increase the cervical curve and performed the MRA with the patient's curves improved. They showed increased pixel intensity representing increased vascular flow to the brain. This sounds exciting and may be, but to extrapolate these findings as many did online is not evidence-based. Here's an example. He states, quote, when they forced the neck into a proper curve, they found that it improved blood flow to the brain by 200%. This is very exciting because it shows definitively and possibly for the first time that improvement in curve of the neck improves blood flow. Interestingly, one of the main hypotheses associated with Alzheimer's and dementia is that it can be caused by a lack of blood flow into the brain, a condition called chronic cerebellar hypoxia, and there is also evidence that ADHD in children may be associated with poor blood flow to the brain, unquote. How about a more evidence-based summary? A single case series publication using MRA determined that after using a device to improve supine cervical curve measurements, MRA pixel intensity increased by 23% to 235.9%. Regression analysis indicated that 33.8% of the possible changes in observed pixel intensity can be attributed to the initial measured cervical lordosis. In other words, only a third of the effect of the change in pixel intensity was due to the change in cervical curve. The required sample size to produce a significant correlation between lordosis and change in MRA pixel intensity is an N of 16 to give an 80% chance of achieving a p-value less than 0.05. However, This study involved only 7 patients. What did we learn? Statistical significance does not necessarily mean clinical significance. Short-term response using an indirect measure does not convey any sense of clinical significance. For example, if correction occurs only supine, are the benefits only lying down? What happens with gravity added and associated muscular interactions, and that effect on blood flow? This blogger's connecting Alzheimer's and ADHD represent logistical stitching, connecting basic science ideas with clinical science, allowing extrapolation from one to all. So the results were statistically significant. What is statistical significance? Imagine you want to hire someone whose education is based on a pass-fail grading system. All you know is that they are minimally competent, but you can't distinguish them from someone who may have scored significantly higher on testing. In other words, the quality of their education and knowledge. The same is true of literature evidence. Statistical significance simply means minimally competent from the perspective of science. What we must know clinically is the effect size or difference of effect, one that patients would perceive as meaningful. For example, although a study may be clinically significant in the difference between 2 groups, if the study was pain and the difference between groups was 1 on a 10-point scale, is that something patients would feel differently or value that difference compared to the other group? So what happens when studies don't prove that what I do in my practice works? Well, first of all, what's the purpose and design of research? In an effort to minimize bias and chance, researchers study a well-defined population using inclusion and exclusion criteria. They compare at least 2 groups, see if there's a significant difference between or among groups, which is statistical significance determined by p-value, confidence interval, and power, and then determine if that difference is small, medium, or large to determine clinical significance. This is determined by differences in effect sizes. So the question is, can you do the same with your practice observations? That's a rhetorical question. Let's look at an example of what many would claim is not representative of their experience in practice, especially sports practices. 4 studies showed SMT had no effect on physiological parameters at rest or during exercise. There was no effect of SMT on scapular kinematics or transverse abdominis thickness. 3 studies identified changes in muscle activation of the upper or lower limbs compared to 2 that did not. 5 studies showed changes in range of motion, 1 study showed an increase in lumbar proprioception, and 2 identified changes in baropodometric variables after SMT. Sport-specific studies showed no effect of SMT except for a small increase in basketball free throw accuracy. The summary? The preponderance of evidence suggests that SMT, in comparison to sham or other interventions, does not enhance performance-based outcomes in asymptomatic adult populations. A pretty specific statement. So what do we need to know? That systematic reviews are at the top of the hierarchy of evidence. Systematic reviews do not study patients. They study studies. Regardless of how many high-quality studies, the researchers of a systematic review must rate them and report on what they find. Screening for bias, heterogeneity, and power eliminates less valid studies. So don't shoot the messenger. The analogy could be, what if you were assigned to judge a gymnastics event without knowing the rules of the sport, the scoring rules, and the statistics involved? Well, you enjoy gymnastics, so you can have an opinion about whether you liked what you saw. An opinion is your right. But you don't have the knowledge or skill to critique the performance, nor the judges. And what if you scored the performance a 9 out of 10, yet the mean score for judges was a 5? Can you simply ignore their determination? They're the trained experts, and you're not. Yet many chiropractors discard or even use ad hominem attacks on researchers who conduct systematic reviews and conclude that there is insufficient evidence for manipulation for a given condition. So what are the researchers actually saying? Not a comment on the effectiveness of manipulation, but the lack of evidence. When reviewing the results of studies, you have to check your ego at the door. It isn't about you or your profession, your team. It's about a narrowly defined subset of patients and treatment approaches focused on by that research study, in an effort to minimize the bias likely seen inadvertently by individual docs. And a final excuse used by many, often quoted, is that 90% of all research is flawed or false. This essay is likely the source of most of those concerns. This researcher is correct in many of his observations, but these are more intended to warn consumers of research to be cautious, to be an evidence-based reader. His concerns are focused on power and bias, the number of studies, the ratio of true to no relationships, and small effect sizes. He's also concerned about financial and other interests. What solves these concerns? Systematic reviews. They don't study patients, they study studies, and, if they're meta-analysis, they study RCTs. The purpose of systematic reviews is to determine not only the number of qualified studies, but rate them for quality based on risk of bias, heterogeneity, statistical significance and power, clinical significance through effect size, and, if statistically similar, portrayed as a forest plot. Here's an example, where all the studies in a meta-analysis are graphically presented with weighting for size and often quality of each study. The effect box reflects the size and/or quality of the study, and the line represents the confidence interval and its relationship to the center line of no difference between groups. And the bottom diamond represents the mean of all studies taken together. So clearly, to be fully evidence-based, a working knowledge of what research is and how it's reported is requisite. Where do you get this information? There are many sources. A great website is the Centers for Evidence-Based Medicine. Also, in Michael Hainline's text, The Evidence-Based Chiropractic Practice is a great professional-specific source. The appendix at the end of my text's 5th edition, Differential Diagnosis and Management for the Chiropractor, gives a 25-page summary of the language and process used in incorporating literature into practice. A quick video tutorial can be found at Coffee Break U, the Evidence-Informed Chiropractor. Click on the EB Tools link on the upper left banner. This takes you to 4 free video tutorials that in total will take less than 2 hours to review, and of course, you can go back and refresh your knowledge. Other sources include podcasts. There are quite a lot. Here I'll mention a few, including Chiropractic Science with Dean Smith, iChirocast with Stephen Pearl and David Newell, and the Forward Thinking Chiropractic Alliance with Bobby Mabey, and the Evidence-Based Chiropractor with Jeffrey Langmaid. Each interviews leading researchers in an effort to provide listeners with a unique perspective from basically the horse's mouth about a particular study or a group of studies, what they were designed to do, and what the results actually indicate. So dig in and complete this triad.